Welcome, everyone. There are a few people online. Welcome to the special grand rounds. And we're fortunate we have a guest who is also here being considered for a position as head of a division of gerontology in the Department of Epidemiology and Public Health. And that's Keipp Talbot. She's a professor of medicine and health policy at Vanderbilt University Medical Center. As a dual appointee in medicine and health policy, she's played a pivotal role in the evaluation of RSV in adults and the evaluation of new and existing vaccines in older adults so as to improve immunization policy and vaccine development. Her goal is to continue to evaluate the use of and effectiveness of vaccines with a focus on prevention of infection and comorbidity in adults. Her recent work has contributed to our understanding of the epidemiology of SARS, of influenza, and RSV, and she's a voting member of the Advisory Committee on Immunization Practices and has served as chair of the ACIP, that's the Advisory Committee on Immunization Practices, Influenza Vaccine Work Group, and co-chair of the COVID-19 Vaccine Safety Technical Work Group. She's authored more than 200 manuscripts. Her work has informed national policy on the implementation of enhanced influenza vaccines for older adults, the use of pneumococcal vaccines in the setting of changing epidemiology, and COVID-19 vaccine introduction and use. She currently leads the Tennessee Emerging Infections Program at Vanderbilt, which works to better understand viral respiratory disease epidemiology and inform vaccine policy. So, welcome, and here is you're all set up. Hopefully things will work.
You're missing the snotty nose part of the picture, which will become relevant in a minute. I am no longer on ACIP, which means my head has come up out of water and I get to think about doing other things, and hence I'm here. I'm very excited about this. I do study viruses, but I believe they have a huge impact on aging adults. And so you'll see this kind of crossover and we'll talk about that. I also tend to like to see who I talk to. So, and the button to push is over here. So just bear with me, please. All right. So there's this whole conversation about Tripledemic that hit the news. Well, we're not going.
Click there, and I should just have to click.
Perfect. So all my funding is from the CDC, and this is not reflected in the CDC. All right, so these are the news headlines that really came out last year. We had just gotten through COVID, or mostly through COVID. We're still having huge hospitalization rates. And we started really testing for viruses and found that it wasn't just influenza and COVID, it was RSV. Everyone thought this was a new epidemic, a new virus, but believe it or not, it's been around for a long time. Yeah.
May I ask you to minimize the video of the attendees?
Yeah. You want to see the slides?
Okay. And you can also get rid of the floating thing if you go under, I think it's under more. And you can say hide floating mail meeting controls. Yeah. That one. There you go.
All right. Now you can actually see.
I'm teaching this during every.
I'm sorry, you could have seen the snot. Okay. All right. So this is the, now you can see this is CDC data of respiratory syncytial virus. And this is total number of cases over the years. So in 2019, 20, 2020, 21, and then 21, 22, actually, this is 18, 19, 19, 20. In 2021. So when everyone was home behaving and wearing their masks, we had no viruses except for rhinovirus circulating. We had a bit of an early summer season. And then in 2022, 23, we had this huge spike. And that's when the media got all excited. The reality of the fact is we were really beginning to test for viruses and different platforms were being used in hospitals. I also think people hadn't been infected for a while and their immunity had dropped. So it was probably a double-edged sword, but we saw all this.
Yeah, if you.
There we go. All right, so we're gonna talk about the discovery of the virus, we're gonna talk about virology, we're gonna talk about clinical presentation, we're gonna talk about immunity, which is incredibly important in our older adults, vaccines, because we know I'm a vaccine, we have two, and a third one's on the way. And there's actually no treatment, so I don't really know why I put that there. All right, so this is a chimpanzee. They actually get what they call chimpanzee coryza agent. Coryza as in runny nose. And this is actually a sick little chimpanzee, but a few years after it was discovered, someone was actually looking at infants that were being admitted and saw the same virus and renamed it respiratory syncytial virus. So we can get it, and so can chimpanzees. It's in the family of RNA, it's a RNA virus. So just like COVID, just like flu, it's another RNA virus that wreaks havoc. There are two major antigenic groups. They don't really change much. You know, flu changes year to year, but this stays the same. They cause annual winter epidemics, and it's like clockwork. I'll show you some studies pre-pandemic. And it's actually the leading cause of lower respiratory tract in children. So it is the #1 reason kids get admitted during the fall winter season. There's another virus that's still in the subfamily called metapneumovirus, human metapneumovirus, and you'll start hearing more about that virus, and we'll talk about that briefly. All right, so why is it called respiratory syncytial virus? Well, this virus actually makes a protein called the fusion protein. When the virus enters the cell, it puts these fusion proteins on the outside of it. And it combines with other cells and makes what's called a syncytia. And if you look at it, this is the only basic slide I show, I promise. It begins to form these syncytia, and then they all kind of die. This is how we used to diagnose it in these little flasks years and years ago. All right, so this is the virus itself. It's actually not a round sphere like everyone thinks it is, but there are two proteins that are incredibly important. But the most important is the F glycoprotein. It's that fusion protein. It's the one that everyone's immune system recognizes. And it is actually the one we're going to talk about when we talk about vaccines. All right. So this is the F protein. There is a shape before it binds, and there's a shape after it binds. The different colors are kind of the antigen sites that the immune system recognizes. You'll notice post-fusion, they're completely different. Okay, and you have antibodies which can bind and do nothing, and you have neutralizing potency. So these bright red are the most likely to neutralize the virus and keep it from doing harm. All right, so just remember that we're going to come back to that multiple times. All right, clinical presentation and diagnosis. So this is what we learned. We start off with kids. They get bronchiolitis, they get tracheitis, they get pneumonia, and they get otitis media. All children are infected by 2 years of age. So as we age, or as we are no longer less than 2, every infection that follows is a reinfection. So this is not like measles. I gave you measles, which I would not do. You would get it once and be done with it. But RSV will haunt you over and over and over again. They did these beautiful family studies and looked at the attack rates in families. And you'll notice the highest attack rates are in the little kids. But you'll also notice the family studies stop at age 45. And what they saw in these families is a cold-like illness. So we go from really severe disease in kids to a cold in adults. And so no one worried about RSV after that, except for the kids. They all worry about the kids. A side note that is, as adults with our colds who come to work, we're rather infectious. So that's important to remember too. It wasn't until the 80s and the 90s that we started seeing outbreaks in nursing homes. And these are just 2 examples of outbreaks. It has a high infection rate once it gets introduced into the nursing home. These were probably introduced by adults going to work with their colds and thought, I'll just suck it up. And it spreads rapidly and has a high mortality rate. Before we could easily diagnose RSV in nursing homes, however, these patients got lots of antibiotics. We put them at risk for Clostridium difficile. We put the nursing homes at risk for these very resistant organisms. And they continued to occur over time. And we'll talk about a recent outbreak that still no one thought about RSV. All right, oh, I want to do one thing about this. People died of all kinds of stuff following RSV. We were not very good at recognizing RSV as a cause of death. So they would say heart failure, COPD, things like that. So if you go back and look, you're not going to see a lot of viral infection as the cause of death. All right, so this is actually an, I guess I should not tell you where it happened. So there's an outbreak in one of the nursing homes near us. It had units A and B. There were double occupancy rooms. One of them was an Alzheimer's memory care unit. There was one box of gloves for both units. There was one gown. And they had removed the alcohol hand gel because one of the patients with memory problems was drinking it. They start having an outbreak. They had 10 cases within 4 days, and it continued. They actually started oseltamivir because they thought of flu. I'm giving credit for that. But the outbreak was actually RSV and human metapneumovirus. And you'll notice really high infection rates, 70% or more, and 15% of the patients in Unit A died. So a significant mortality. All right, so we now know that RSV is not the typical cold in older adults. It may have lower respiratory tract symptoms. It is often a cause of exacerbation of congestive heart failure and lung disease. And these patients are often afebrile, and that won't surprise this group because you know in older adults, we don't always create the necessary interferon to do that. All right, so now we have the whole spectrum of disease. We know the whole spectrum. No testing was done, and we'll talk about that for years. So everyone knows about this part of the board. Some people have learned this part, and now, thanks to commercials, everyone's learning this part. All right, so testing for RSV, there are a couple problems. The first one is culture. Like that slide I showed you, they had these flasks, and it was very dependent on who was reading the flasks. When I was an intern, they still did that. They had this huge machine that would keep them warm. They actually also wrote down the RSV positives in a book. But anyway, so that worked if a patient was in hospital. If a patient's at a nursing home, though, it's likely that the virus would die before it hit the microbiology or virology laboratory. So it wasn't very sensitive for that reason. Rapid antigen tests like we use for influenza and COVID are awful for RSV in adults. For kids who pump out virus like a machine, it works very well, but in older adults, it doesn't. DFA and IFA, we used to take specimens and put them on a slide and then stain them with something that would fluoresce. But it required the person actually who's really good at doing this to find it. PCR revolutionized our world. It's not 100% sensitive, but all of a sudden we could diagnose this virus. Now, it's expensive and there was no treatment. So no one tested for us. And I would try to get the emergency room to do it. I was like, why don't you just test everyone for flu and RSV? This is pre-COVID. And I get, you're going to pay for it? I'm like, maybe if you'll do it. They're like, no. And then serology is very sensitive. I draw blood on you when you start getting sick. I draw blood on you 4 weeks later. Totally useless when you're trying to diagnose somebody acutely though. All right, so epidemiology. So there was no testing. So how did we figure out how much RSV there was? So there was a lot of mathematical modeling. Actually, Dr. Newsel back there did some of it. Where they looked at when RSV was known to circulate and looked at the pneumonia and influenza hospitalizations and estimated the number of RSV hospitalizations. No surprise, like the earlier graph, you see a lot in the less than 1 and a lot over 65. I do want to point out though, something happens around the age of 50. 50 to 64-year-olds start having viral respiratory disease like influenza and RSV.
What's the unit on BY?
I actually can't remember.
I can see.
No, it's
Yeah, I think it's more. I think it's more than 1,000, but I will find out. So somewhere between 50 and 64 is probably a group with lots of comorbid conditions that are seeing immunosenescence earlier. And how you pick those out, you'll know, is incredibly difficult to do in a standardized recommendation type of way. And many of them are minority groups that may or may not be insured during this time period. So Marie Griffin, who's one of my advisors, this is 1,000 for 1,000. Actually looked at data in the nursing homes. It was pretty remarkable. They saw 15 hospitalizations for 1,000 residents. 76 courses of antibiotics were given, which doesn't treat virus at all, despite what some patients will tell you. And there were 17 deaths for 1,000 residents. So it's impressive. So Ann Falsey and Ed Walsh up at Rochester have done these beautiful studies. Carolyn Breezy was there and did it in kids. And they kind of took it a step further and looked at it in adults. And they looked at it over 4 years. They had a hospital cohort and they had an outpatient cohort. And what they found is of those hospitalized with an acute respiratory illness, 10% had RSV. 15% of those required ICU care and 8% died. They did a back of the envelope calculation and felt like there were over 170,000 hospitalizations per year due to RSV in the United States. We were actually doing surveillance at the time that was population-based, so we were able to look, okay, we have our denominator because we have population-based. We know how many patients are hospital in the other hospitals we do surveillance in, and we were able to calculate the burden of illness. Just so you know, we only had 6% of all hospitalizations, but those were adults over 50. And what we found was a lot of RSV, more than anyone thought. Now, the second column is RSV, the third column is influenza. This is per 100,000 people. In the 50 to 64-year-old group, there was more influenza than RSV, not a surprise. But what we found in the 65 plus is there was a lot more RSV than influenza. And we think this is because this group gets vaccinated. A high proportion get vaccinated for influenza. And so probably without the vaccine, this number would be higher. But in the setting of vaccines for influenza, a number of hospitalizations for RSV is probably higher than flu. So Ann Falsey's group at Angela Branch did another one. So they did another population-based study, much bigger than the one that we had done in New York City and Rochester. And they looked at all adults over 18. They looked at those that had symptoms of acute respiratory illness and those that were coming in with exacerbation of heart failure or anything like that. And they tested for RSV and they looked at the number positive in their surveillance area. And they actually found 1,000 adults with RSV. And I show you this slide because these are 3 different years. It's 17, 18, 18, 19, and 19, 20. And sorry, I do years in terms of viral respiratory season. I don't think of them as normal years. You'll notice in these 3 years, the seasons, the number of infections in those seasons almost completely overlap. So RSV is a much better behaved virus than influenza. It will come when it's supposed to and it will leave when it's supposed to. Really, there's some variation, but very much the same. So as we continue to do this, we started talking about how do we do this on a bigger platform? How do we look at RSV? How do we know how much RSV there is? Because if we introduce a vaccine, we have to have a baseline. So the Emerging Infections Program is actually a collaboration between academic medical centers and the state health department and the CDC. Maryland has one. And we look at hospitalizations within defined catchment areas. So our catchment area in Nashville and the surrounding counties. It's 18 hospitals, including 2 VAs, which sometimes give us data and sometimes don't, but we found a solution. And we collect all kinds of information and are able to look at the numbers of burden. So we began surveillance in 2014-15. Anyone who's diagnosed anyway for RSV were captured. And this is that earlier data that you saw. That's where that data comes from, is this study. So what we found, very similar to the early studies that were done that were smaller, it's the adults over 75, it's the adults with COPD and CHF, asthma, the nursing home population, not the I'm coming in for rehab and leaving, but the nursing home population, and those that are immunosuppressed. And these are hospitalizations by age. So the top line are those over 85, then over 75, then over 65. So the real burden of disease is in those over 85. Congestive heart failure is a risk factor for hospitalization. So the blue are patients with CHF and the orange are patients without CHF. And no matter what age group, if you have congestive heart failure, you're more likely to be hospitalized for RSV than if you don't have congestive heart failure. All right, so let's talk about immunity. I don't have to tell you when I do infectious disease talks, I have to explain frailty and they still look at me like I have no idea what I'm talking about. But frailty is a huge syndrome that is associated, we're finding out more and more with the risk of infection and the response to vaccines. And as you know, it's also not just about the age of the patient. There are a lot of factors that go into frailty and it makes it very difficult. Okay, so this is a study, don't look at the slides yet, that'll overwhelm you. So this is a study looking at the degree of frailty that patients had and their response to pneumococcal vaccination. As patients became more frail, low, moderate, and severe, the less likely they were to respond to the vaccine well. Okay, so there's definitely a difference. Similarly, the study was done in influenza. So non-frail, pre-frail, frail, on the left-hand side shows you that those who are most frail have the lowest antibody responses to influenza vaccine and are more likely to get flu, probably because they don't make a good immune response to immunization. So there have been a lot of challenge studies. Most of them are in young, so we can help figure out what would be protective. We haven't learned what it is yet, but I'll take you through some studies. So there were healthy adults between 18 and 55 years of age that I gave RSV to. Now these were healthy, so they had the common cold. They weren't sending them to the hospital. They found that 36% became infected. That's not right. This should be 50%. And of those, the majority were symptomatic. So you can get an adult near RSV and they'll catch it. And they looked at what was associated with this. And lower IgA antibodies, so the antibodies that hang out in your nose and your throat, is associated with infection. They really didn't see any difference in the serum neutralizing antibody. And that's because these were all young and healthy. If you look pre and post infection, antibodies are lower. You get infected, and 28 days later, your titers are way up. And then within 6 months, your antibody titers are back where they were prior to infection. So it's not a sustained response. So someone actually looked at immunity in younger versus older adults. And the median age was 26 for the young and 74 for the older. So not as old as some studies could be, but older. And what they found is that the antibody responses in the young and the old were similar. And there was no difference between the serum or the IgA. So the reason for infection in older adults was not just the presence of antibodies. And what they found was interferon gamma response. So the interferon gamma is in either the closed circles or squares that were clear or the elderly, the older adults. And that they have much lower interferon gamma response when they're exposed to RSV or proteins of RSV. And interferon gamma is actually what causes you to have a fever. So it explains why there's a difference. They also said, okay, there's no difference between old and young, but what if we looked at the frail elderly and looked at who was infected and who wasn't? You actually see lower antibody responses in those that are frail, and they're more likely to get infected. So really not a surprise. And we'll talk about why this is so important. We do vaccine studies in older adults. They tend to do the Senior Olympics and read in the mind, and they're not pure normal. All right, so reinfection is often. In the older adults, it's due to evasion, which is due to interferon gamma mediated. And one thing to remember is our own immune system hasn't figured out how to protect us from this virus long term, which means we're probably not going to do much better because our immune system has been evolving for millions of years. But it also means if we develop a vaccine, we need to have some limited expectations. We're not going to give a vaccine and they're going to be protected for life. Question, how long, we don't know. All right, so this is the study that actually identified people who had RSV and then re-challenged them. Once again, these are all healthy adults. No one's done this in older adults. And they reinfected them at 2 months, 4 months, 8 months, 14 months, 20 months, and 26 months. Yeah, I wouldn't have done that study. And the highest number of participants who got sick were that 2 month, which is pretty surprising. But people were still getting infected over and over again. And this slide kind of shows you 67% were reinfected at least once. 47% were infected at least twice within 2 years. And actually, remember, they had it and they got exposed twice. So this is probably more like 3 times. And as I mentioned, the highest reinfection point was at the first challenge time. All right, so we know this is a bad virus. We now can test for the virus. We don't have any treatment options, so it can be prevent. The first vaccine studies were actually done in kids. They took the virus, they killed it in formaldehyde, and then gave it to children. And you'll see that they did, instead of a placebo control trial, they had the formalin inactivated RSV vaccine, and then they gave them a parainfluenza virus vaccine. And the same number of kids get infected. So the vaccine didn't work, back to the drawing board. But really they had to go back to the drawing board because those who got the formalin inactivated RSV were more likely to be hospitalized. They actually had 2 deaths. Needless to say, that rocked the RSV vaccine world. It really kind of changed the dynamics and the speed at which this was done. And this was 1969. And we're talking about a vaccine in 2020. So it really did. It's 50 years. These are, I didn't tell the truth. I had another pathology slide in here. This is to show you what the lungs look like in the kids that got RSV vaccine, which is not what was supposed to happen. All right, so why does this happen? There are a couple of things that happen. The formalin activation wasn't done exactly right. So we had some misshapen virus. The other part is if you give virus in the post-fusion, your body makes protein antibodies to this area with very low neutralizing potential. So it binds, but doesn't do any good. Actually, there's some complex, I'm getting the C word, complement deposition, the whole 9 yards. And so it really became an issue. And the question is, how do you give a vaccine that's only in this form? And so Barney's Graham group, who actually did this for COVID too, was able to stabilize this fusion protein. They made some changes and they could actually give it in the pre-fusion F form. Really exciting, changed the whole dynamics of this field. Actually, also, just so you know, discoveries like this were incredibly important for COVID. So they had figured out with the first SARS, this information. And so we actually had a head start when SARS-CoV-2 came along. All right, so there are 3 vaccines for older adults that have been developed. 2 are now licensed, and 1 is in the pipeline. Did you all do these studies at the Vaccine Center?
Not the RSV ones.
Okay. So Pfizer did 1 and they've used it in pregnant women. GSK did an adjuvanted vaccine, and we'll talk about what that is. And they scrapped their pregnant persons. And then Moderna is in the process of getting FDA. So Pfizer took that pre-fusion F, put it in a vaccine, and they did not use adjuvant. I don't usually put up table 1s, but there's a reason there's a table 1 up here. And you just have to look at the red box. The number of people over 80 was only 5%. The majority of the patients were 60 to 69. So they didn't see any hospitalizations and they couldn't figure out why. And they're like, it's a severe disease. I'm like, you didn't enroll anyone who would be hospitalized. And this was the number of pre-specified medical conditions, existing medical conditions, only 50%. We talked about the people who get hospitalized are frail and have lots of comorbid conditions. So once again, they did not enroll the target population.
These were excluded.
You know, they excluded immunocompromised or anyone with unstable medical problems or anyone who probably would have been admitted with RSV. And also, I mean, you know this, if you're looking for the 80-year-old who's frail to do a study, you're gonna have to go to them. They're
They
not,
have to what?
you're gonna have to go to them. They're not driving in a clinic for an extra
True.
event. And hopefully they're not driving. All right. And y'all probably know this better than I do, but the number of comorbid conditions rises with age. And so it's very telling that they had so few. The vaccine worked. It prevented lower respiratory tract infection. They didn't have data for hospitalization, but there was a 66% reduction in those if you had 2 symptoms, and if you had 3 symptoms, it was an 85% reduction. So pretty impressive. The idea is if you can prevent lower respiratory tract infection or infection, you probably prevent hospitalizations, but we really don't have any data in those who are at risk for hospitalization. And the reasons I showed you the flu and pneumococcal stuff earlier is because we can presume that there will be lower antibodies and lower responses if you're frail. All right. They had some serious adverse events. Yeah. So they had a Miller-Fisher syndrome, which is a variant of Guillain-Barré. They had 1 allergic reaction and they had 1 Guillain-Barré. So of the 30,000, there were 2 cases of Guillain-Barré. They were all in the treatment group and not the placebo group. The rate of Guillain-Barré increases with age. And it's really hard to know if this was spurious or if it was actually associated with a vaccine. GSK did the same pre-fusion F, slightly different picture, and added an adjuvant. So the idea of an adjuvant is that it's something that stimulates the immune system. They used to do this with horses when you were trying to get serum immunoglobulin from them. They'd rub dirt into the spot before they gave a shot. We don't tend to rub dirt in people's arms before we give them a shot. That's considered unethical. But we have found other compounds to do this. And so they have added one of those compounds, which is an ASO. And it's very good at causing an immune response. So if you get this vaccine over the other, your arm's going to hurt more. Once again, though, they did a little bit better. They had 8% over 60. They did a timed walk and called it frailty. That was the only measure they did for frailty, and 1% were considered frail. And only 40% had more than one, at least one or more than one comorbid condition. So a healthy population. Their vaccine effectiveness was, efficacy was really good. So it was 82%, and that prevented lower respiratory tract. They also surprisingly did not have enough hospitalizations to make a comment on hospitalizations. They had no cases of Guillain-Barré in their phase 3 trial, but they did have 1 case in their randomized open label trial. That was only 1,000 participants. And so it's unclear, once again, if we're seeing a relationship. I do say for GSK, they did something interesting. So with their Arexvy vaccine, they did a repeat trial every couple of years. So if you received vaccine the first year, we either gave you re-randomized either to vaccine or placebo. And they did it for season 3, which we don't quite yet have data on. The interesting thing was that your vaccine efficacy for year 1 was 83%, and year 2 was 56%. And it was the same whether you got vaccine or didn't get vaccine. I have no clue why. I've actually called Barney Graham a couple times to try to figure it out. So we don't know when to redose, which is kind of important. All right, so this is my soapbox. This drives me crazy. When we do older adult vaccines, we do these really young, healthy folks. They have few comorbid conditions. There's little to no data on frailty, and the other, they're probably not frail. There are no nursing home patients. I showed you all that data of RSV and nursing home patients, and none of them were included in the study. And they're never powered for hospitalization for that reason. Okay. That's my soapbox, I'll get off. All right, so when it comes to safety, we're looking at some prevention of disease, but we're also looking at an unknown risk of Guillain-Barré syndrome. The recommendation that first came out was you and your doctor can have a conversation and decide if you need an RSV vaccine, which is a horrible recommendation because most adult doctors don't know about RSV, and so how they're going to have a conversation about a disease they don't know. Really, we need to look at risk. If you're really high risk and we think your risk of RSV hospitalization is higher than Guillain-Barré, you're the one who should be getting the vaccine until we find out more information about Guillain-Barré. And we will. There's several safety systems. The FDA has one, CDC has one, and they're also doing one through the Kaiser network. So we're getting data, just it's going to take a while. All right, so we talked about this. All right, we've talked about this. That was my soapbox. Okay, so really in conclusions, RSV infection does not cause durable or complete protection. The extremes of age are at the highest risk of morbidity and mortality. Older adults have weaker interferon gamma responses, which leads to more severe infection in the setting of their other comorbid conditions. And that these vaccines may provide protection, but we have a lot more information to find out how well does it work in the nursing home population? Does it work in the nursing home population? How often do we give this vaccine? So I think we're a long way from being finished, but there's still a lot more. And these are all the wonderful people who helped with all this work. Happy to take questions. Yeah.
I'm welcome. I'm happy to see you here. I'm Justin Ortiz from the Center for Vaccine Development. I have a keen interest in immunization in older adults. One thing I know you know a lot about, so I'm going to ask you to hear some more, is that we often in our observational studies or in the clinical trials we have these endpoints, which is laboratory confirmed infection during a medical visit, right? Or I guess we're looking for laboratory confirmed infection during hospitalization. But particularly in older adults, there's a kind of a broader public health value of vaccines. You talked about the impact of frailty as a risk factor, but I'm very curious on how well do we understand kind of the return to baseline, like the functional baseline. Once somebody has an infection, all right, they're counted as a outpatient care, so a hospital case. But what do we know about their trajectories, especially if they're frail and older, and what more can be done?
Yes, we don't have a lot of that data. Actually, my PhD epi student is working on that. But I have pushed while I was at the ACIP that their economic modeling for older adults needs to include the cost of care after hospitalization. Because we know some never return to their baseline function. They don't ever return home. And so that cost of care has not been included traditionally in the economic analyses. And so we badly need to know what it looks like post-hospitalization so that we can actually have those numbers to include in those analyses.
Just naive question from non-vaccine.
Yeah.
So I was kind of fascinated by this data that you have vaccine and you have certain efficacy like 80%, and next year same vaccine has no efficacy. So can it be like antibiotic selection in bacteria?
Yeah.
So you just erase this particular strain and basically you accelerate mutagenesis and appearance of new variants.
So that actually is a great question, even for a virologist or a vaccine person. There is some efficacy still in year 2, it's 56%. We just can't boost it back up to 80%. The virus doesn't really change like the flu virus or like bacteria who develop resistance. So there's some theories in other viruses that you either don't respond a second time, or there's competition, or these other problems that we see with other viruses like influenza that we're not seeing here, so we can't figure it out. So I think there's some studies in the bench that need to be done. But it's fascinating. Because I think the expectation was we were gonna get this vaccine every 2 years. And I don't know if that's right.
What's different to those viruses in the following year?
They're usually the same.
I want to go back to the question about the functional sequelae of infection. I think of course adding cost and hospitalization would be important. But I think there are other functional deficits that older people will have and never wind up in the hospital,
Yes.
nor in a nursing home, that are very important to consider. And those also need to get factored in. So I wonder if there's any even recognition on the part of those developing these vaccines and testing them. I don't mean like you as an investigator, I mean in terms of the regulatory bodies. Does anyone really care that you've omitted so many people that really are the most vulnerable? And that also what kind of consequences there might be in that population and what can be done about it?
So I've had an off the record conversation with someone at the FDA. There is a split camp on this issue.
Is it what, split?
Some feel like that these patients at risk need to be included. Some do not. I think there's a concern that if they required that the pharmaceutical company would have to pay much, much more for their studies and it would take longer to do.
That's true.
And I've actually had a conversation, I don't think we're gonna have like a whole study of people who are 80 and frail. But I think there needs to be a balance and there needs to be a conversation where we're not on either side of the spectrum. And really trying to push that conversation.
It could be a requirement that a certain percentage of
Yes.
of the sample
Yes.
needs to be X.
Yes, yes,
This is not unusual. This is true of
Right.
most drug trials to begin with, whether it's vaccine or not. So this is not new.
no, but it still
It's
needs
still
to
there.
be fixed.
Yes.
Yeah.
Oh, I'm gonna, so I can understand, having worked in these older adult populations, the challenges to doing clinical trials. Having said that, you gain an enormous benefit. You go into an assisted living to do recruitment. Because you could basically, I mean, you could just base your whole study team there.
Yeah.
And at some of these places, you would get, you could have 100 people enrolled and do those sorts of things. So is it real? I mean, really? Is it going to increase cost? I'll just throw that out there.
Where I've heard that the companies have to track adverse events. And there are far more adverse events that have to be tracked and tracked down. So that when we were doing the early bone density studies and wanting to treat people in nursing homes, we were told we can't do that. There are too many adverse events, which is a very simple answer, but maybe that's part of the cost
It's a
factor.
huge part of it.
Because they're reportable and they have to be tracked down and they need to be.
I'm with you. I'm with you.
Yeah, and
But
it's actually
that's-
interesting.
But that's the simple answer, but we've got to overcome that.
Almost all vaccine studies previously have been done by pediatricians and they're phenomenal. They do great work. But they don't see adverse events like we do.
Right.
They don't see heart attacks and hospitalizations and strokes. And so it was interesting. Some of the early studies when we started doing adult vaccines, more than half are pediatricians and they're like, oh, there's something wrong with this vaccine. And we're like, no, this is what it's like in our world.
Right.
Like you ought to try to take a history in the hospital. It's totally different. Yeah, Justin.
So in fact, I think people still think Kathy's pediatrician.
Yeah.
But, the prospective studies, are hard and, you enroll a lot of older adults, you're gonna get a lot of adverse events, which are hard to track And, when we're talking about rare outcomes, certainly like Guillain-Barré, you're not going to identify that in a clinical trial. But, this speaks to the power of the, kind of the large, data set of studies that you mentioned, Northern California, Kaiser and the like. And this is more of a comment for everybody else in this room, with this Institute for Health Computing that I know very little about, that, is being, developed in Montgomery County within the University of Maryland. I see tremendous opportunity. We have access, and again, I don't know much about this, but we have access not just to health records within Maryland, but I think that they're paying for access elsewhere. Tremendous opportunity for vaccine safety studies, for observational, maybe not VE, but maybe like relative VE studies. Wouldn't it be cool to assess the and important for public health to assess the performance of these different vaccines against one another, especially if one has this Guillain-Barré syndrome or a signal and others don't. And so I think that we have a great deal of opportunity here in Maryland with these new tools that are becoming available.
It would be phenomenal. Kathy.
Yeah, just as a follow-on, you probably know that Ann Falsey is doing an immunogenicity study in nursing homes this winter, which is great, right? And not surprising. But I'm curious, I mean, a lot of the great work that you've done in Tennessee is, as you said, the emerging infection network, the Tennessee Medicaid, Medicare databases. Do you guys have anything planned to look at the frail elderly or the long-term care or NBSN? Is CDC thinking of expanding that to older adults?
We are not yet. We are looking at a cohort, but they're of working adults. Now, we do get working adults over 65, but once again, they're going to be much more healthy, or although some of them have not been healthy, and household studies. So we do capture some grandparents, but there's no funding for older adults.
Population based.
No.
Okay.
Which would be lovely. There's also, so probably some of you in the room know, some don't. COVID is one division at the CDC and influenza is another division, and they get separate budgets. And so some studies, they've played really well together and we've been able to maximize efficiency. And then there's some other studies that flu funds and then COVID funds. And so all the administrative databases, everything have to be duplicated and it's incredibly expensive. And yeah, it's yeah.
I have a question about frailty. I love that you're including frailty, but then there's part of me that says, yeah, but what is it about frailty?
Yeah.
Like, it's made up of like 5, if you use Freed's definition, right? There are multiple components that contribute. So what is it about frailty? It's a marker of health status, right, in general. So is there something else, like, is there one component that's driving that vulnerability that you could separate out and be even faster to look at? I'm just curious, like, well, what is it? Is it grip strength? Is it weight loss?
I don't think we have that.
What is it? It's a marker.
It's a marker, I think, of the general inflammation of the immune system. I don't have the slide, but usually when you get infected, there's this great big jump in inflammation and then it comes right back down. And what we see in older adults, the frail older adults, is there's a little bump, but it doesn't go and it just keeps going and going and going. And so I like to think of it as when your kids are young and they're screaming the whole time and you figure out how to ignore them. And then at some point they've actually hurt themselves and you're not paying attention. So I kind of think of that as the immune system that's been hearing the screaming the whole time and is like, whatever.
Or persistent increase in inflammatory responses.
Mm-hmm.
So why not measure that? Like, I love the frailty piece, but it's not connected for me just because I don't know what it is about frailty that would make them more vulnerable.
Janet McElhaney tried looking for a serum biomarker for that. There's good and bad with that, because when we do vaccine policy, we try to do it simple. Keep it simple. Probably and stupid, but if you have to get a blood test to figure out if they're frail or not,
Right.
it's gonna be incredibly difficult to
Well,
do.
that's the same challenge with using age. If you're over 85, you're more vulnerable. Well, that may be true, but we don't know why.
Yeah.
And that's why I know your pictures showed much more variability. And the older they got, the more variable the response was. Which is probably because that's a very variable population, which we know.
And it's incredibly difficult from a diversity standpoint and equity standpoint, truly equity, is that if you are Black in this country and you are 55 and have 5 comorbid conditions, your immune system may look like a 90-year-old woman. So if we vaccinate only those that are 85 and over, there's this whole population that is at risk that we are not
We
capturing.
can't, age is not a good marker. It's a marker, but it's not.
The only. Yeah.
So in clinical practice, people have to get COVID, influenza, RSV vaccination. So people always ask us, well, should we mix and match? What's the sequence? And people generally say, I'll get them each 2 weeks apart. Is there any data on what we should be doing?
I'm gonna let Wilbur answer that because he's still in ACIP. I'm just throwing you under the bus.
I would give them all at the same time because it's probably in many instances, the only time that you're gonna capture them. Not
Guys,
gonna
can you
get them
repeat
back.
what he said? I couldn't hear him.
You give them all 3 at the same time.
Get him at the same
Because
time.
then you're worried about capturing the people and you got them in the office or whatever. Give it to them because it's rare that they'll come back and get it again.
It's vaccinations actually being administered, not, so I'm not worried about these vaccines interacting with each other, which may have like some minor, reduction in the immune response. But overall, in a population, if you're missing, doses because they don't come back or whatever else, they get sick in the interim, then that's a missed opportunity. So I always look at it, I would rather just get it all completed all in one shot.
Bill
Thank you.
Schaffner says,
I mean, if you were in an office, we're all busy. We don't want to have to keep making appointments, so.
so Bill Schaffner says the vaccine's only good once it goes in the arm. It doesn't matter how many you have in the freezer, it's only good. Now, I had mine separated.
But why was that?
Because I want more data on all of them.
Well,
But I chair the safety committee, this is how I think, but this is why, there's different.
yeah, and differences of opinion, but I think that in practice, again, I always tell my patients, you're here, let's just get it done today. You're busy, I'm busy. How hard was it to make this appointment? Yeah, it was hard. Let's just get this done. And so boom, we just do it.
And most practitioners have been doing that. I think that's been
But Keipp, did you also say there's not enough evidence to say you should get the RSV vaccine because of the Guillain-Barré risk?
everything that we do in medicine, there's a risk benefit, and we have to
Right.
weigh that risk benefit. It is clear that those that are high risk, if you're 85 and have CHF, it is clear you need to get an RSV vaccine, regardless of what the risk of Guillain-Barré is. If you're 55 and you have no health problems, I don't know what we're preventing when we give you the RSV vaccine. But
And you
we-
might be putting me at risk for something
Yeah.
else.
Yes. Now, when we know how often RSV actually occurs, then we can actually say comfortably, we know the risk. All those cases could have been related to age and not vaccine, but we don't know that yet.
So you're speaking like an epidemiologist, not a clinic, well, as a
Yeah.
cautious clinician.
Yeah. But I see patients 2 weeks a year in the hospital, that's it. I always am thinking. Yeah,
So I'm glad you brought up, you sort of alluded to diversity, equity, and I was gonna ask, because I didn't really, again, in addition to enrolling older people in these study samples, there also isn't a diverse sample, and I think they
Correct.
were in the 7% range, I
Yes.
think. So clearly, there could be people who are even more at risk if you take their age and their race and their ethnicity and their comorbidity
Yes.
profile. So, but we're not quite there yet with the data to look at that.
well, the vaccine center for their COVID was able to do a diverse population.
Yes, we were.
Yes,
I helped.
yes.
Yes, Yes, we
So
are.
when pharmaceutical companies tell us at ACIP that they can't do it, I'm like, not true, not true. We saw it in COVID, it was doable, got done, and it got done in the middle of a pandemic and everything was crazy and you couldn't get an old person out of their home. I mean, you should have seen the emails I got from older people. I can never leave my home again. Like, just hang in there, vaccine's coming.
It takes more effort, it takes more time, you have
Yeah.
to get out there, you have to
Yeah.
do the community engagement, you've got to do it, but it is doable.
It is very doable. And
Especially in Baltimore, even with all the issues with related to research, across the street. So do you anticipate that there's gonna be more work looking at, racial and ethnic differences?
not by the pharmaceutical companies, and it won't be randomized with a placebo-controlled trial. We will be trying to look at this data in big data sets. If you could get that one going, I would appreciate
I want you to come here and help us.
it.
Yeah, I think the IHC, they are making data, they're curating data. And I think it's gonna be a little while till it's available for wide use. But it needs people to use the data.
Until it's used as junk data is what one of our
I think
faculty
there's
say.
a big emphasis in certain areas, but I don't know that infection and aging in general are their areas, although they do have some investigators now. They're bringing on for that. For
But
the aging, not necessarily infection.
the majority of hospitalizations are in older adults.
Well, we know that.
You know that, I know that, but
Is it recommended for people who work in nursing homes or these older adults to get vaccinated regardless of their?
I love that question. Because there have been some big flu studies that were pretty amazing. So they randomized nursing homes to either give flu shot to their employees or not. Some of them in the not given, still got some. And actually, even the uptake when they gave it to the employees for free was not fabulous, like 40 to 50%. But what they found in those nursing home studies is that the only impact on mortality was vaccination of the staff. If you vaccinate the patients, there's no impact on mortality. But if you vaccinate the staff, there was an impact on mortality. So I really think we need to change the way we think about vaccinating in the nursing home. But that's a whole issue of I'm staff and I'm not gonna get vaccinated to protect somebody else. There's a lot more of that pushback now, especially after COVID. Second thing is right now, I would not recommend a staff member to get it until we know the risk of Guillain-Barré. Unless they were older and had CHF.
Well, let me ask before we end, are there any questions from anyone that's?
There's a chat.
online?
In the chat.
Is it chat? Can you take a look at that?
Yeah, thank you. And I'm assuming that's Brock. If you want to introduce me to your wife, I would love it. Because yes, it is true that I actually one time turned in the pediatricians and said about this issue, this is like testing a vaccine for newborns in a 5-year-old.
So Brock says, get in touch with him and he'll put you in touch with his lovely wife.
Thank you for the translation. That's awesome.
I'll get you in touch with Ross.
I would love that because it's the same issue. We don't test vaccines in teenagers to be used in infants. It makes no sense.
Same problem. Any other comments or questions from anyone who is listening in? Okay, well, I think we've come to the end and I want to thank you for joining.
Thank you. Y'all stayed longer than the hour. So thank you.
It's great. Thank you all for being here.